Check 1 2 1 2. Check 1 2. Hello lovely people, I'm back again with another day in a live video. This time around is during my ICU night rotation. If you're new here, my name is Dr. Acquah, a third-year internal medicine chief resident in New Jersey. You can check out my other day in a live videos in the description box down below. During the day, ICU team sees patients, go for morning report, teaching rounds with intensivist, also known as the ICU doctor, noon lectures at 12, with ongoing teaching events during the day. They manage acute changes in patient stay in the unit, evaluate emergency department patients and admitted patients for ICU admissions or transfers. They update patient families and more. Around 6 p.m., they sign out to the night team, which will be me tonight and my co-resident, Dr. Eliachevsky. Lions gotta eat. We get dinner from the cafeteria before they stop serving hot food at 7 p.m. Prior to this, we usually go around the unit and ask nurses if they need anything for the patient. Let's start with this case. 19-year-old male came in suicide attempt. Usually drugs that are used in suicide attempt, they are common ones that people tend to use a lot, but this one was somewhat different. I'll put the name of the drug there on the screen. So what we did was we got in touch with poison control, and the goal was that we need to closely monitor the patient, monitoring the patient for CNS depression, for low blood pressure, hypotension, and also bradycardia, slow heart rate. Right. So what they had recommended was we keep the patient in the ICU. Then we give fluids. If patient is unresponsive to the fluids, then we consider initiating pressor support, which is a medication we use to hold someone's blood pressure up. Otherwise, with patient's heart rate going down, meaning patient becoming bradycardic, we will be keeping patient on telemetry monitoring and will intervene in case that happens. So with patients like this, it sounds like a psych issue, but then we need to take care of the medical expert first, and then the psychiatry team will take over. Most often than not, the patient has to go to an inpatient psych unit to be evaluated. Please don't kill yourself, all right? You're worth more than you think. Sometimes you have to put the food aside and take care of the acute event. After eating, I do patient chart review and see what was done during the day by the other specialists on the cases that I had admitted overnight. And the goal here is to see if my thought process was in line with their recommendations during the day, or if my thought process was way off. We go from bed to bed using computer on wheels, and patients do appreciate this as they see us discussing their cases and involving them in their care. Here, my friends, is the challenge of the night. I recommend you try as much as possible to stay awake during the 12-hour shift you have during your ICU night. The patients are in the intensive care unit, or the critical care unit for a reason. I'll let you decide on that. Back in the resource room doing some miscellaneous activities on my agenda for the night. Sometimes I read on topics here and there. So what exactly can happen if you rupture one of your major blood vessels? I think maybe the answer running through your head will be that you may bleed, and if it's not intervened on, you may bleed till death. Well, That's a case I have on my hands currently. This elderly male coming from a nursing home, he fell, he was complaining of abdominal pain. When he came here, he was found to have a fracture. One of his bones were broken, but a CAT scan was done, which is currently showing a large retroperitoneal hematoma. So issues like this, if it's not intervened quickly, patient may code on us. So the best thing that we did was we got in touch with the vascular surgeon on call, and fortunately enough, the vascular surgeon came in, and currently the patient has been taken to the OR. How does ICU come into play? Well, if he goes to the OR, most likely he's going to be intubated and he's going to need pulmonary critical care attention. All right, so while seeing that patient, I was told to come to the ICU quickly because one of the patients got agitated and seems like he pulled his central line. I'm heading there now, and hopefully we can replace it. If not, we'll get a chest x-ray, making sure that patient does not have any pneumothorax. It's a busy night. With a situation like this, you first have to figure out why the patient became agitated. Majority of the patients we see are geriatric, so a better option will be to redirect the patient, or sometimes getting a one-on-one observer seals the deal. Nevertheless, if patient become progressively aggressive and start throwing punches at the one-on-one observer or the nurses, then at that point in time, if there are no contraindications, we do try haloperidol, which does the work. So let's see what a triple lumen catheter kit looks like. So for those that have opened this kind of kit before, you know that not everything is included in this particular package. Some of the pieces have been taken out, which were used for educational purposes. But for the remainder of the things in this kit, you can see the drape on the side, the seroprobe cover, also on the bottom left of the tray. So this is the guide wire that goes in after the needle and helps us in placing the triple lumen safely. Yep, that's a knife. Usually we use that to puncture the neck, so we'll be able to use a dilator to allow the catheter to pass smoothly. Everything done is under ultrasound guidance. And in this demonstration, you can see it being placed. The main thing you're looking for here is that you get blood return, and that's it. Yep. So we do get chest x-ray to confirm placement. On your screen, you can see the white arrows. So at, let's say 2 o'clock, you can see that arrow pointing up, and you can follow that line and it comes all the way down to the midpoint of the chest. This confirms proper placement. Critical time during the night is between 2:30 to 4 a.m. That's when sleep tries to embrace you. I recommend you stay busy and active during the night. We have help from the respiratory team when it comes to intubation. An important thing needed here is to know what orders to give the nurses. So know your sedatives and paralytics for the rapid sequence intubation. Doses are weight-based and may vary per patient. So your 70 milligram dose of rocuronium may not be enough for me.
Thank you.
Knowing your arrhythmias is also a must during your ICU night rotation. Back and forth continues until the day team shows up by 6 a.m. We sign out overnight events, new patients that were admitted to the ICU or transferred to the ICU. We discuss the patient that need an extra close attention before attending rounds around 8 o'clock. Big shout out to my co-residents whose faces appeared in this video: Dr. Eliachevsky, Dr. Samad, also known as the Dress Doctor, and Nurse Rose. Big ups to the CCU nurses, to the techs, to the respiratory team, X-ray techs for their help in the ICU during the nights. Sometimes we place lines at odd hours. We get X-rays when patient becomes severely short of breath, and X-ray techs need to just, come and get that X-ray done for us. Anyways, stay blessed, and I'll see you all in my next video. Shalom.